Good morning, everybody. I'd like to thank you once again, EGA Presidents, for giving me the opportunity of being here today. I don't know if we can see the presentation. Yeah, here we go. So we slightly changed the subject from bone block procedure or Latarjet to soft tissue procedure. So what's the main issue with anterior shoulder instability so far? As we learned with the previous presentation, we have so many surgical options. We talked a lot this morning about bone block and Latarjet, but also for soft tissue, we're going to say that we have a lot of options, and probably the main issue is that we have too few certainties, actually. Why? Because the easiest algorithm we can remember is that when we have critical bone loss, for sure, we need bone procedure. When we have no bone loss at all, which is probably only after the first dislocation, soft tissue procedure as a standard bunker repair is fine, but what's in the middle? What's the gray zone? The gray zone when we have hyperlaxity, multiple dislocations, so tissue quality is uncertain, number of dislocation, functional demand, the presence of a small ill sex lesion associated with a subcritical glenoid bone loss. What to do in these cases? So we already say in a multiple presentation that the problem with arthroscopic bunker repair is that redislocation rate basically are too high. So bunker repair has been the standard of care in anterior shoulder surgery after multiple dislocation with no glenoid bone loss or subcritical glenoid bone loss, but redislocation rates are still too high. And this is a nice paper that showed that probably bunker repair could be the best option only after first time dislocation, which, that's quite impressive. In the previous presentation, we heard that probably is okay to operate patients after the first time dislocation, even if they are not athletes. And apparently, this is the best spot to do a bunker repair. So this surely increased the indication to bony procedure, such as Latarjet. We already saw these papers, and we learned that the problem is not only the redislocation rate. For sure, Latarjet surgery is a very, very effective surgery for stability, especially if you do it when you do not have such a huge bone loss. For sure, it will be a success from a redislocation point. But we need to know that it's not an anatomic procedure and the rate of complication is pretty high. So what could be an alternative? An alternative, when you do not have a critical bone loss, it could be to add a remplissage to a standard bunker procedure. And apparently, this is pretty effective in lowering the recurrence rate. But once again, at least my hand, I don't think this is an anatomic procedure, and basically usually patients affected by shoulder instability are pretty young, so my goal would be to do something anatomic as much as possible. This is a comparative study with comparing bunker plus remplissage and Latarjet procedure, just saying that especially if you do not have a critical bone loss, bunker or remplissage is pretty safe. But let's focus on the pathology. We know a lot of things about bone defect because our algorithms are basically based on the evaluation of glenoid bone defects, but just try to focus our attention on soft tissue. And when we talk about soft tissue, we talk about labrum. So what's the characteristic of this labrum and capsule, which is surely at least stretched or disrupted after an episode of shoulder instability. So let's talk about labral first. Labral insufficiency. When can you find a labral insufficiency? It can be an anatomic problem. Patients affected by multidirectional instability could have labral insufficiency besides a capsular redundancy, or you can have a very old ALPSA tear, and it's very difficult to find what remains of the labrum. That's a labral insufficiency, and this is another study that showed that when you have a small labral morphology, you have a higher risk of postoperative redislocation if you just repair the labrum. So what's my solution, which actually this technique was first described by another brilliant Italian surgeon, which is Enrico Gervasi. We're gonna hear later from him about this technique, which is the labral augmentation. Labral augmentation, what does it mean? It means that, you'll see in a second, I'm gonna reconstruct the labrum by using a membrane just to deepen the glenoid concavity and increase gingival surface area. Enrico described the technique for multidirectional instability. Actually, I'm using it also for anterior shoulder instability or traumatic posterior shoulder instability when I do not have a sufficient labrum to be repaired. And I use a membrane. The technique is pretty easy. I roll up the membrane, I suture it, and I obtain a kind of roll or cigarette pretty similar to the labrum. Technique is pretty easy. I measure the defect, the length of the defect. I prepare the surface, and then it's just kind of a standard Bankart repair with the incorporation of the new labrum. I pass a suture through the capsule, so I can put my membrane, my new labrum into the joint, and then I just incorporated the new labrum in a standard Bankart repair. So it's very easy, it does not require a huge learning curve to be performed. And you can put as many anchors as you want. Usually I use 3 anchors like in a standard Bankart repair if I'm repairing only the anterior labrum. As described by Enrico, you can use that also circumferentially. So we try to do a first trial, a sort of pilot study on 20 patients with anterior shoulder instability, just anterior shoulder instability. And we see that the results from a clinical standpoint were very, very good. We had only one redislocation, which was traumatic, no other complication, not intraoperative, not postoperative. And these are the results when you look at the MRI. Basically, if you compare the anterior labrum with the posterior labrum, you can see the integration, the height, the thickness of the labrum. So it's very simple procedure, very anatomic, and very successful, I would say. I also use this procedure in revision cases. If there is no bone loss, if the main issue is soft tissue, I try to look at soft tissue once again. And of course, as first described, I use also in multidirection instability. Are there any other option if you don't have a membrane? Yes, you can use an autologous semitendinosus or gracilis allograft, and just in the same way, just producing the same results. Some other technique have been described by using the biceps, so you can keep the proximal part of the biceps in this technique, the Duro technique. Another technique described by an Italian guy is the ASA technique, the arthroscopic subscapularis augmentation. It's a kind of tenodesis of the upper third of the subscapularis tendon associated with a Bankart repair. I'm proud to present a study from the shoulder committee of the SIAG Ascot. We just compared the use of ASA, remplissage, Latarjet, and arthro-Latarjet. Basically, this study showed that ASA or remplissage are pretty effective as a soft tissue procedure compared to Latarjet. They show similar results when you think about functional results. But once again, if you look at complication in Latarjet were pretty higher compared to soft tissue procedure. So for sure, this is an alternative. And then for the rest of the world, BLS technique, an anterior extracapsular stabilization between glenohumeral ligament and subscapularis tort, described by Roman Broska a few years ago. And then the most famous destabilization. So you can use the biceps by detaching it from the proximal part and just keeping the conjoint tendon effects, but also reconstruct the labrum by using the biceps, the proximal part of the biceps. Another recent procedure is the subscapularis link procedure by using a semitendinosus autograft once again. What my preference, as you show in anterior shoulder instability, arthroscopically, I usually use the membrane, as I show, or the semitendinosus tendon. But If we have connective tissue disorder, so the problem are all the soft tissue, the labrum could be insufficient, the capsule could be insufficient. Once again, I use a rolled up membrane or a semitendinosus graft to reconstruct the labrum, and I can do a capsule augmentation, as you can see in this picture, by using the semitendinosus and the gracilis together, and the two strands reconstruct the middle glenohumeral ligament and the anterior part of the inferior glenohumeral ligaments. Or if I have a small defect, I can use a bone augmentation and soft tissue augmentation, just taking semitendinosus and gracilis autograft or allograft with a small bone plug. That's up to you. In case my problem is everything, so I miss, like in this case, half of the glenoid, but I also have a soft tissue problem for sure, then I can use an Achilles tendon allograft to address for the bone and for the soft tissue. In conclusion, when I use only the labral augmentation as a static procedure, simply in recurrent anterior shoulder instability, when I have a labral insufficiency, and then I can use a membrane, I can use a collagen scaffold, I can use a tendon graft, whatever I like, even the biceps, the concept basically is the same. When I use a capsule augmentation as a dynamic procedure, when the problem is not only the labral anymore, but also the capsule, due to recurrent instability, due to connective tissue disorder, is always important to evaluate the patient, to visit the patients, don't forget it. In conclusion, key factors in treatment strategy. First, take your time to evaluate the patient, take your time to understand the pathology. You are working on very, very young patients, so try to restore anatomy. That should be the main goal. And for sure, bone defects matter, are very important, but please never underestimate soft tissue. That can be a game changer in your surgical approach. So before thanking you, as I already said yesterday, I'd be honored to be the scientific coordinator of two very, very important meetings. One is the ESCA meeting, that will be held next year in Milan. So please join us. Abstract submission deadline is in mid-September. We would be happy to have you there. And the Siagascot meeting in 2025 that will be held in the south of Italy, in Napoli. So I'm waiting for you. Thank you.